So I think we can start with Dr. Dreyfus. It's a real pleasure to have you here on a hot topic. Uh, but I don't want to present you because Eman did a great job, and I would like Eman, please, to present our host today at the DCB Academy lesson.
It's my pleasure. So good day, everyone, and welcome to a new DCB Academy session. We're honored to be joined by Dr. Julien Dreyfus, an imaging cardiologist from the North Cardiology Center in Saint-Denis, France. Dr. Julien is recognized for his pioneering work in the first-in-human transcatheter tricuspid valve interventions and for his unique expertise at the intersection of imaging and structural intervention. In today's session, he will guide us through an overall approach to the management of tricuspid regurgitation, including transcatheter solutions. Dr. Julien, we're happy to have you with us, and the stage is yours.
Thank you very much for your kind introduction. So it's my pleasure to talk about management of patients with tricuspid regurgitation. So first, we have to be aware that TR is associated with significant mortality and morbidity. And when we mean morbidity, it's heart failure hospitalization, but it's also impairment in quality of life. The recently published European guidelines suggest with a class 1 indication to perform a careful evaluation of those patients with several parameters that should be assessed. The first one is the assessment of the severity of the tricuspid regurgitation, knowing that assessing TR grade is really challenging. That's why they suggest a multi-parametric approach with qualitative, semi-quantitative, and quantitative parameters. But and you understand here with the transgastric view that the anatomy of the tricuspid valve is very different from one patient to another, and that's why you understand how challenging it is to really assess with the current tools we have the severity of the tricuspid regurgitation. Another important point is that TR grade should be assessed in euvolemia, and you can see here the same patients before diuretics when he came for heart failure during the hospitalization. And then after intravenous diuretics, you can see a significant decrease of TR grading, meaning how important is the time of echo for TR grade assessment. The second point is to assess the etiology, the mechanism of TR, knowing that there is a new classification with functional or secondary TR, meaning that there is no disease of the tricuspid valve itself, but it's more the remodeling of the right atrium and the right ventricle. Organic TR, it's a disease of the valve, of the leaflets, for instance, carcinoid, rheumatic, endocarditis, and then CID related. If we focus now on functional or secondary TR, there are now two new entities, atrial and ventricular TR. If we try to make something simple, because things are much more complex, atrial TR mean usually in patients with chronic atrial fibrillation, a significant enlargement of the right atrium, then a tricuspid annulus dilation, and due to the tricuspid annulus dilation, then there is a significant gap, but the RV is not so dilated and stay quite triangular. On the opposite, patients with ventricular functional TR, you have a significant remodeling of the right ventricle, which is more ovular, with a significant remodeling with displacement of the papillary muscle, inducing a tethering of the leaflets. So if we would like to make it simple, atrial functional TR is tricuspid annulus dilation, ventricular TR is more about significant tethering, but unfortunately, most of the patients are in between those two possibilities. And then if we now focus on CID, we have many patients with pacemaker. Approximately 1/3 of patients who are currently treated with transcatheter devices have a pacemaker or defibrillator. And there are two possibilities. Either you have patients with a CID and TR, but the CID is not inducing the TR, which is really frequent, or a lead-induced TR, meaning like in this case, you can see that there is a significant impingement, a restriction of the mobility of the septal leaflet due to the pacemaker. So the pacemaker is responsible for the TR, which we call lean-induced TR. Then, third very important point is to assess LV and RV function and pulmonary pressure. And once again, not easy to assess. That's why we need a multi-parameter approach with standard echo, but also advanced echo and sometimes CMR to help us to perfectly understand the size and the function of the right ventricle and the left ventricle. TR, or patients with TR, represent a very heterogeneous population with many phenotypes. And why is it important? Because according to the phenotype, you will have a dedicated management. For instance, if TR is induced by the CID lead, then maybe you should consider extracting the lead. If it's atrial fibrillation, maybe we should consider atrial fibrillation ablation. If there is severe MR, we should treat MR. So specific management according to the phenotype. And then TR is also associated with different impacts. Impact on the right ventricle, impact on the cardiac output, impact on the liver, on the kidneys, etc. And what is now clear, what has been demonstrated, is that the more impact on different organs of the TR, the worse the prognosis. So dedicated management according to phenotype, prognosis related to TR severity and impact. And since a couple of months, we have specific management guidelines that has been suggested by Fabien Perez and team and published in European Heart Journal, suggesting both surgery and transcatheter intervention according to the heart team discussion, and we are going to discuss this further. So the first thing is that heart team discussion should be should rely on a dedicated, a standardized pathway of the patient, and then we can think what would be the best strategy for the patient. It means that we should assess the patient history and symptom to confirm the severity of the TR, to evaluate the mechanism, the etiology, to assess the RV size and function, the pulmonary pressure, the feasibility for a transcatheter intervention, and then to assess its stage and the risk of any intervention with the TriScore. If we start with surgery, surgery is currently recommended in patients with severe TR who are symptomatic if there is no significant RV or LV dysfunction and no severe pulmonary hypertension. So we have really clear guidelines. However, unfortunately, only few patients are referred to surgery, and the main reason is the surgical risk, because if we look at published papers, we often see around 8 to 10% in hospital mortality rate, which is quite a very high rate, and that's why most patients are not referred to surgery. We have developed a dedicated risk score model to predict in hospital mortality after isolated tricuspid valve surgery, called the TriScore, with 8 easy to ascertain clinical, biological, and echocardiographic parameters: age, NYHF functional class 3 or 4, presence of right-sided heart failure signs, daily dose of diuretics, kidney function, liver function, left ventricular ejection fraction, and RV function. And the score ranges from 0 to 12 points, knowing that when you have 0 points, predicted in hospital mortality rate is 1%, and that this rate increases up to 65% when you have at least 9 points. And it is really important to understand that this score is based on patients that were truly operated, meaning that until recently, some patients were operated without knowing that 2/3 of them will die right after the intervention and will never be discharged alive. We suggested, and I will display it further later, we suggest to consider 3 categories. Low TriScore category when you have 0 to 3 points, intermediate TriScore category when you have 4 or 5 points, and high TriScore when you have at least 6 points. This score was developed in France, and it works for both functional and organic TR. You can see that patients with functional TR had a significantly higher TriScore compared to patients with organic TR, and that's why patients with functional TR had a higher rate of deaths than patients with organic TR, knowing that for each number of points in hospital mortality was the same regardless of the mechanism of TR. It was developed in France, I told you, but then there were some external validation in Spain, in Italy, and even in South Korea. So it seems to work worldwide, and you can easily calculate it with free online calculator, either with the website or with a free app. It's really fast and easy. If we look at Tricuspid is a large international center gathering more than 50 centers in 13 countries. Patients with isolated TR for whom we had a TriScore. And there were three groups, a medical group, a surgical group, including patients with isolated tricuspid valve surgery, including both repair and replacement, and a group of transcatheter valve repair. For the moment, we work only on repair, as replacement has been recently available. If we first try to compare mortality at 10 years between surgery and medical therapy, overall, we didn't find any survival difference between the two groups at 10 years. First, very importantly, according to the TriScore, mortality rate is not the same, meaning that if you have patients with low TriScore, in hospital mortality after surgery is very low, less than 3%, while if you increase the TriScore category, the surgical risk become very high. And that's why we are currently, I have the pleasure to chair a randomized controlled study comparing levosimendan versus placebo before isolated tricuspid surgery, and we will see if proposing this treatment may decrease the surgical risk. If we now look at survival at 10 years between surgery versus medical therapy according to TriScore category, you can see that survival benefit after surgery compared to medical therapy was observed in the low TriScore category, but not in the intermediate or the high TriScore category. And if we now divide the surgical group between surgical repair and surgical replacement, there was still surgical benefit of intervention in low TriScore, no benefit of surgery in the high TriScore category, and benefit in the intermediate TriScore only in patients who had surgical repair, but not in patients with surgical replacement. Meaning that if you treat early the patients, you may have some benefit. If you treat patients too late, there is no benefit. And for patients at intermediate, probably patients who require a surgical replacement are sicker than patients who may have surgical repair. And this works also after redo isolated tricuspid valve surgery, meaning that we frequently have patients with dehiscence of the tricuspid annulus, surgical annulus, or we may require a valve-in-valve intervention. So when we discuss valve-in-valve or valve-in-ring intervention versus surgery, we may use the score. And you can see that after redo isolated tricuspid valve surgery, survival at 5 years is very high, as well as survival at 5 years free of heart failure readmission. If we now move to the transcatheter solutions, for the first time in the guideline, it has been suggested with a class 2A indication to perform a transcatheter intervention in patients with severe TR, and they were very fair, considering that if you do so for your patients, you may improve quality of life, you may improve RV remodeling, but we currently have no evidence regarding any survival improvement. We have several possibilities. The first one is repair, and for repair, it's mostly used currently worldwide is the edge-to-edge repair with either the TriClip from Abbott or the Pascal from Edwards, who are both CE marked, FDA approved, and reimbursed in some countries. Regarding replacement, it may be orthotopic or heterotopic. We will focus on orthotopic because you will be able to correct TR. And only one, the Evoque from Edwards, is currently FDA approved, CE marked, and also reimbursed in several countries. And there are some others like the Topaz or the Lux Valve that are in the process to get those approvals. Very important is the selection of the patient to define if the anatomy is suitable for any transcatheter intervention, and you have several tables that can help you. Here are probably the most important parameters that should be assessed with echo, including both transthoracic and transesophageal echo. You have first the gap, and the gap should not be too large. If you have a large gap, you won't be able to catch the leaflets. Then the leaflet morphology, if you have 3 leaflets or less, which is rare, it's quite feasible. If you have much more, for instance, a star shape with 5 leaflets, it will be much more challenging. The location of the jet ideally should be central or anteroseptal. If it's a diffuse jet or too posterior, it may be much more challenging. The number of papillary muscle and caudal, the less you have, the best it is. And then if you have no CID, it's easier than if you have CID. And if it's a TR-induced, CID-induced TR, then it won't be possible to do edge-to-edge repair. Same if you have a significant test ring, the patient won't be a good candidate for any edge-to-edge repair. And that's why you have the color just like for the mitral valve, considering that on the left part, probably the patient is anatomically suitable for edge-to-edge repair, while if you are moving to the right side, you should consider a transcatheter tricuspid valve replacement. A score called the GLIDE score has been proposed to help us to define those patients or the patient that may be suitable for transcatheter intervention. I would like to focus on a few important parameters. The first one is the image quality. And what is really exciting with this kind of intervention is the fact that we're working together as a team with both an interventional cardiologist and an echocardiographer. And if you would like to perform any transcatheter repair, then you need to see perfectly well the leaflets. Unfortunately, in some situations, and I have here an example with patients with mechanical mitral prosthesis, you can see that there is a shadow, and unfortunately, you can see that there is severe TR, but you are not able to clearly define or see the leaflets. And for those patients, now you have the possibility to use the intracardiac echocardiography, which allow you, because you will be directly in the right atrium, to perfectly see the leaflets, and therefore to be very helpful during the intervention. And here you have a case with very, very beautiful 3D image before the intervention with severe TR, and after intervention, after implantation of 2 clips, and excellent results. So something that could be very useful in our practice. The second important parameter that I would like to focus on is the fact that when you consider a tricuspid valve, you say that you consider that there are 3 leaflets, but this is not totally true. And this was a preliminary seminal work from Becky Allen, who say that in fact the tricuspid valve was not a 3 leaflets valve in many, many patients. And this is really impactful, because the less leaflets you will have, the easier it will be to perform any transcatheter intervention. And you have here several examples with 3 leaflet valve. Here is a bicuspid valve. Is a 4 leaflet valve, and you have here different example. And this is really, really impactful, I told you, because when you have 2 leaflets, a bicuspid valve, it will be really easy, just like mitral valve, to perform the intervention. If it's 3 leaflet valve, it will be feasible. But the more leaflets you have, and the more challenging it will be, and associated with poor results, as lastly demonstrated in several studies. And we have done this work with Becky and the team from Padova, who are anastomopathologists, and they did an amazing work trying to look at the anatomy. And what that they observed is that among 100 cadavers, human cadavers, they looked at the heart, at the tricuspid valve, and they observed that 3 leaflet valve were observed only in 41% of patients, while the most frequent anatomy was a 4 leaflet valve with 2 posterior leaflets that we call P1 and P2. So this is really important now to be aware that in fact tricuspid valve is mostly a 4 leaflet valve than a 3 leaflet, and this is really impactful for our daily practice, especially when considering edge-to-edge repair. So what are we expecting with edge-to-edge repair? First, you have to understand the anatomy and the physiopathology of the valve and the annulus. When you have a tricuspid installation, this will occur at this free wall, meaning at the anterior and posterior level, the lateral side, while the septal leaflet is anchored at the level of the septum, at mitral valve, the aortic valve, so it won't move, it won't dilate. And that's why when you are considering edge-to-edge repair, you try always to anchor the anterior leaflet to the septal leaflet or the posterior leaflet to the septal leaflet. So always between anterior and septal and posterior and septal, and never between anterior and posterior, because it won't be impactful on the dilation. And then you will consider two possibilities, and there is a lot of discussion to choose the best strategy. Either implant two anterior and septal clips, or one anteroseptal and one posteroseptal, knowing that with anteroseptal you may be very efficient on short term, but if you want to be efficient on long term, you should catch both anterior and posterior leaflet, because if you treat only the anterior part, then the dilation will occur in several years at the posterior leaflet. So probably, and my personal preference is to treat both anterior and posterior to be sure that you will be efficient on long term. So if I try to show how it happened during transcatheter edge-to-edge repair, so it will be a transfemoral access. You will be guided by both the fluoroscopy and TE. First, the interventional cardiologist will bring the guide into the right atrium, and the echo guy will try to guide him or her towards the right atrium to the tricuspid valve. And then there are two views that are very useful, that are mandatory. The first one is the mid or distal esophageal view, and you can see here showing the clip at 70 degrees with the biplane view, because the biplane view will help you to define which are the leaflet, the septal and the anterior, the septal and the posterior. And the second important view is the transgastric view that will help you to define the orientation, to be sure that you are well oriented and that you will catch the leaflet. And you can see here transgastric view with an anteflexion of the probe to perfectly see the clip. So usually you will implant one first clip which will be anteroseptal. If your strategy is to treat only the anteroseptal part, then the first one will be quite commissural. So this will be the first one, and then you will add a second one which will be more central, and the second one will be probably the one who will be the most efficient to decrease TR. And you can see here the final result with two parallel clips and a residual grade, very mild residual grade, so an excellent procedural result. The second possibility is when you have a patient with not only a central tricuspid regurgitation, but also a posterior regurgitation. And in this situation, you have to treat both anteroseptal part, but also the posteroseptal part if you want to be efficient. And this is what we did in this case. And you can see the first clip that will be anteroseptal and the second which will be posteroseptal. And I didn't mention the fact that you always start with the anteroseptal one, because when you are doing transgastric views, if you start with the posteroseptal one, then it may prevent the echo imaging quality to perfectly see the anterior one. So always you start with the anterior and then you move to the posterior. So I was mentioning the edge-to-edge repair, but unfortunately, in many cases, edge-to-edge repair is not feasible because, for instance, you have a large gap, or you have pacemaker lead, which will prevent any clip attachment. And in those cases, you may consider a transcatheter tricuspid valve replacement. Here is an example with the Topaz device, which will be also guided with both the fluoroscopy and transesophageal echo. Sorry, I think I have to move this. And you can see the final result with no more residual TR, excellent result, assessed with both the angiography and the echocardiography. And then you can see with the CT the perfect placement of the device with an excellent result. Another possibility, for instance, because you have several devices, is the Lux valve, which is a Chinese device, and you can see as well at the end an excellent result with those replacement device. You can use also those devices when you have pacemaker lead, and you can see the patient before the intervention with severe TR and the pacemaker which was posterior, and after intervention, no residual TR even at the level of the pacemaker lead. If we now look at the baseline characteristic of patients that were included in either registries or randomized studies, you can see that the mean age is 70 years old. Most of the patients are female. Most of them are really symptomatic and NYHA class 3 or 4 are in atrial fibrillation, 90% of them, and approximately 1/4 to 1/3 of them have a pacemaker or a defibrillator. Interestingly, if you look at the three randomized controlled trials that we have to date, comparing transcatheter interventions versus medical therapy, you have Triluminate for the TriClip in the US, TriFair also with a TriClip in France, and Triation 2 with a replacement device, the Evoke versus medical therapy. The three randomized studies were positive if we consider composite endpoints, including quality of life, so this is really important. But if we focus on heart failure hospitalization, there was no benefit of any transcatheter intervention. And if you move to survival as well, like for heart failure, there was no benefit of intervention. Interestingly, if you look in the medical arm, not the transcatheter arm, the medical arm, you can see that survival at 1 year was significantly different from one study to another, from 5% in TriFair to 15% in Triation 2. So the question we're always wondering is, what is survival at 1 year or even more in patients with severe TR who are medically treated? And you can see that if you use the TriScore categories, the more severe, the higher the TriScore, the worse the survival at 2 years. And this is true not only in the medical group, but also in the surgical and transcatheter group. And interestingly, approximately 40% of patients with high TriScore were dead at 2 years, regardless of the strategy, meaning that probably when you are treating those patients too late, you may improve the quality of life, but not the survival for most of them. That's why timing of intervention is key. If we now compare transcatheter therapy to medical therapy at 2 years, I previously compared surgical management to medical management at 10 years because we have longer follow-up for surgery compared to transcatheter therapy, which are more recent. There was no survival benefit at 2 years overall. If we now look according to TriScore category, there was no benefit of transcatheter intervention, and we found benefit only if we look not only at the TriScore category, but also the procedural success, and we define procedural success as a mild, moderate, or lower TR grade. And you can see that this result is achieved in approximately all patients after surgery, but only 2/3 of patients after transcatheter repair, and that's why I told you how important is the patient selection. Sorry. If we now look at those two parameters, we found a survival benefit of transcatheter repair in patients with low or intermediate TriScore, no high TriScore, because probably high TriScore, they are too late, and only on patients with procedural success, meaning that when you are not able to achieve a good result at the end, you won't improve survival. Currently, grading TR, the current scheme is in 3 grades, meaning no, moderate, or severe. And you can see that the more severe the residual TR after edge-to-edge repair, the worse the survival at 2 years. And this scheme is different from MR because for MR we have 4 grades, 1, 2, 3, 4. And what we have demonstrated is that if you divide the moderate TR into mild to moderate and moderate to severe, you can observe that patients with mild to moderate have a significantly better outcome than patients with moderate to severe. Mild to moderate being closer to mild and moderate to severe closer to severe than mild to moderate and moderate to severe. And probably what we suggest is to consider that moderate TR is too heterogeneous group and that we should divide it into mild to moderate and moderate to severe, just like for MR. And we have suggested this refined grading in both the European Heart Imaging Journal and the JZ to try to convince both the European and the American. And this is really important because you will harmonize MR and TR, so you will speak the same language all together for those valves, and also to define procedural success when residual TR is mild to moderate or lower. And this is really a nice example of what we should expect from a transcatheter intervention. In fact, we should do just like the surgeon. We should try to achieve the best result. And this situation, for this patient, we have implanted a leadless pacemaker because you know that a CID may prevent us to performing transcatheter repair. So to avoid having any lead crossing the valve, we implanted a leadless pacemaker. And then we perform a zipping of the valve with 4 clips, 2 anteroseptal, 2 posteroseptal, and you can see that they are perfectly attached, just like a surgical stitch. And at the end, you can be sure that the result is perfect. And 2 years later, the patient has not been hospitalized since the intervention is feeling much more better. And unfortunately, currently, if you look at all registries or randomized studies, approximately 1/4 to 1/3 of patients have no, unfortunately, they don't have a procedural success after this intervention when considering procedural success as mild to moderate or lower. And on the opposite, when you are implanting a replacement, a biprosthesis valve, then you will abolish TR in almost all patients. And this was with the Evoque or with the Etopass, but regardless of the device itself, replacement allow to abolish TR. And this has been demonstrated, and based on this, we have new guidelines that the more you reduce TR grade, the more significant will be the remodeling of the right cavities, RVE, right atrium, and tricuspid annulus. The size of all ventricle atrium and tricuspid annulus will significantly decrease if you abolish or if you significantly decrease TR. And this is also a nice picture showing the same patient before and after, and 1 year after. Sorry, it was 6 months after the intervention, and you can see a significant remodeling of the right cavities. But nothing is perfect because with replacement you will abolish TR, but it is also not as safe as structural repair, because you can see that more than 3% in hospital mortality rate, which is quite high, is higher than surgery in low TriScore patients, significant rate of new pacemakers, significant bleeding, meaning that it's not safe, perfectly safe. So that's why we have to improve management of patients with both repair to have better results and try also to decrease mortality and complication after replacement. So what we have suggested for the management of TR is to discuss with the heart team based on the disease stage, the futility, the risk assessment with the TriScore, but also the feasibility of transcatheter intervention. And when I mean feasibility, you may be able during your patient selection to say if you can expect a mild, moderate, or less TR after transcatheter repair. And if you can predict that you won't be able to achieve this result, you should consider another strategy. And you have the different strategy with medical management, surgical, transcatheter. And so for us, what I would say is that benefit of TR correction will depend first on your procedural success. When you are successful, you will improve quality of life. And now all studies have demonstrated this. You will improve quality of life. If now you would like also to improve survival, probably stage of disease is important. Like we should treat patients at earlier stage as defined by the TriScore. And I like this slide with a smiley showing that the more severe the TR, the less smile you will have on your face, meaning that probably we should intervene a bit earlier in the course of the disease. And this is a publication that is not specific for TR, it's for heart valve disease in general, but it's also true for tricuspid. We should be aware of the importance of the lifetime management, meaning early referral is associated with better survival. Heart team discussion, we should discuss as teams. Tailored strategy, it could be surgery, it could be transcatheter, it could be medical therapy as well. Optimize first intervention. Unfortunately, I often hear that because it's transcatheter intervention, it's safe, so we don't care about the results. No, we care about the results, and the result should be perfect, either for surgery or for transcatheter. That's our goal as physician, and we have shown that the better the final results, the better will be the outcome. Balance for sure, short and long-term outcome. It's not the same if you are treating patients who are 70 years old or patients who are 96. Preserve surgical expertise. This is also really important, and improve patient care and system efficiency. And just the last slide to say that you can calculate the tri-score in your daily practice very, very easily. So thank you very much for your attention.
Thank you, Julien, for this beautiful lesson on a topic that is still neglected because it's poorly understood, to be honest. It's still poorly understood. As you said at the beginning, we studied about the tricuspid in a med school, but then that until a few years ago there was no option. Okay, you can increase diuretics in this patient, but that's it. That's the only thing you can do. So now, finally, this valve came back into the center of the treatment of our heart failure patients, and this is very good. Also because you clearly show that it's not only a matter of a new toy in the hands of interventional cardiologists, no? Because, at the beginning, that was the impression. So you fixed coronary artery disease, removing, taking off many patients from cardiac surgery. Then you started with the aortic valve, then the mitral valve, then the tricuspid valve. Then the next one is the pulmonic valve. But so you clearly showed that there is a clinical need for an optimal treatment of our patients, and this is the way to go. So thanks a lot. We learned really a lot from your lesson today.
Thank you very much. Thank you.
Any questions for Dr. Dreyfus today?
I just want to say thank you so much. It was really insightful and detailed the way we actually need it. Beautiful. You've covered everything. As you said, it is your baby. I can tell. So my question is, how long would you give a chance for a patient on medical therapy before you decide you'd go for a transcatheter intervention?
This is an excellent question. In fact, I didn't present this because we have just submitted it yesterday to a journal. But in fact, we try to work with machine learning to define. I like your question because it's exactly what I mentioned, meaning that currently we are not able to predict mortality in patients with severe TR who are medically managed. We don't know, because some patients, you can have them during 10 years with 40 milligrams of furosemide, and it's okay. While for others, they will die or they will come with right heart failure signs. So what we did is that with machine learning, we look in the medical group, because now we have thousands of patients in each group, and we define 3 groups of patients in the medical group according to survival at 2 years. So we defined patients with 10% mortality at 2 years, which is very low, and patients with 75% of mortality at 10 years, which is very high, and in between, patients who are in the middle. So we had low risk, intermediate risk, and high risk of death in the medical group. And then what we did is that for each subgroup, low risk, intermediate risk, and high risk, we compared the medical group to the surgical and transcatheter group. And what we observed is that in patients with low risk of event, low risk of death, there was no survival benefit of any transcatheter and surgical treatment, meaning that those patients, nothing is going to happen, at least during 2 years. Maybe it could happen later, but nothing will happen. If we now look in patients with intermediate risk of event and high risk of event, we observe survival benefit with both surgery and transcatheter intervention. And we did a 2-step staging. So the first one was based on the machine learning model, and then we look also according to the tri-score, and we divide the population into low or intermediate tri-score, because I told you that low or intermediate seems to be the good candidate, and high tri-score. And what we observed is that in the intermediate risk of event and high risk of event, there was significant benefit on survival with both surgery and transcatheter in low or intermediate tri-score, but not in high tri-score. What I mean is that probably we should treat patients who are intermediate or high risk of event, not all patients, but intermediate or high risk of event, if they have low or intermediate TRI score, and probably those patients are the best one.
That's really not a
But
big step.
and with this, we were able to predict that triluminate trial would be a negative study. Because in triluminate trial, the mean patient was a low risk of event patients, like for TriFR. So you have patients with low risk of event. So at 1 year with your randomized study, you can predict that you won't be able to improve survival. So you can predict that there will be negative studies. So this is really interesting because it may help us to define who are the best patients to treat, and maybe also to define the next studies with the good candidates, because there is always the question of how many patients I should include.
Great. Thank you so much.
Thank you very much for a very nice talk. I had more a philosophical question. So, with the patients with severe TR, most of them tend to be, sort of secondary or functional, and they most tend to have advanced sort of RV disease. I guess, are we treating these patients too late in the sense that, you're waiting for severe TR to show itself? And are we treating these patients once the sort of RV function has sort of gone down this slippery slope, and whether you think there might be sort of RV function cutoffs or pulmonary pressure limits that can better predict, which patients should have earlier intervention?
This is also an excellent question. What I would say is that RV function is really, really important and we have to assess it. However, there are two things. The first thing is that RV function matters, but because it's really difficult to assess with the current tools, either in echo, CMR, or other, especially when you have patients with severe TR, in fact, it's not really useful in our daily practice. If you look in the TRI score, it counts for 1 point, meaning that it's important. With multivariate analysis, the RV function was an important parameter, but only for 1 point, meaning that you have also to assess the other. And what I often observe in my daily practice is that usually when you have significant severe TR with RV dysfunction,